Hello everyone, how are you all? Thank you so much for joining our today's session. So we are just waiting for all other candidates to join actually. So let's start our today's review session on psychiatry. Okay, so those who are in Facebook in the live watch, please make sure that you guys also can comment on the Facebook group on whatever question you are having. So I will have a look on the comment section and then I can answer you. The Zoom ID is already provided in your group multiple times. So if you haven't got your Zoom ID, make sure just scroll down in the Facebook group that you are in the first aid AMC MCQ group. You should get it in any of the posts. We have been giving posts for the last, like, I think 14 or 15 days. So if you just scroll down or up, you should get your Zoom ID and password. Okay. All right. So let's start our review session today. First of all, let me welcome you to the trial session. For those of you who don't know about me, my name is Dr. Arshan. I will be your coordinator for AMC MCQ preparation for the next 5 months. Not for all of you, like those of you who are going to join our next session. So you know that our session is gonna start on 31st of March. So we're really excited to start a new batch again. So there was on December last year, if you guys scrolling down in our Facebook group, you should see that a lot of candidates has passed from our group. And also on February, there was only two students who appeared and both of them passed. So it's really a good thing that we are getting consistent with our candidates to pass in the exam. And we have got a really good recommendation for all of the previous batch students. If you look into our Facebook group, you will see that most of our candidates, they are pretty satisfied about the course, the materials that we are offering and everything. So still, I know that it's quite confusing to to know a course just by doing one single class. So that's why there will be a 2 weeks free session for all of you. So just to know about the course a little bit more. So I know, like, taking a class just for one time and asking you to join a 5 months course is not actually a good thing to do. And honestly speaking, like, anyone can take a massive like the best session just in one class, and all other session can be like just a normal or subnormal. So to know anything better, you should always ask any of the other course also that you want to join at least first 2 3 weeks, just to know about the course, just to know that how you are going to get help from this course, because you are giving 5 months of your life on this particular thing. So it's really important, and you don't want to get into one course, do it 5 months, and then come back in another course, do it 5 months. In this way, you will just longer your preparation, and someone will say this is the correct answer, someone will say no, that's the correct answer. So that will be like a kind of haphazard preparation. So always stick to your own plan, find out the course which is better and well suited for your preparation, and you know what is better for you, you know what you are lacking of, so you can make your decision after taking few sessions with us. All right, so that's fair enough, I think. So we'll start our psychiatry today. Now, psychiatry session mainly we take always, like, if any of you had a trial session with us last time when we started this previous batch, so you should see that we took this same class, psychiatry class, with the previous candidate. So we make sure that our schedule remains same, so that if anyone joins in the middle of the course, so that they can get the left out things in the next batch. So that's why we usually stick to the same schedule all the time. So for you guys also, it will be pretty much same schedule. So we'll do the psychiatry session today. This session is the most important psychiatry session for all other classes that we are going to take. So make sure that you understand it. The second thing, that in the next 2 weeks free session, we will mainly do cardiology and some other chapters. Okay, so you'll get your 2 weeks free session. The schedule will be uploaded tonight in your first aid AMC MCQ group. Make sure that you already know about the schedule and you make yourself free to get into this free 2 week session. It's really important because you will at least have an idea that how to start your preparation. Okay. All right, guys. So let's start the session. If you guys have any question about the course, ask me at the end of the session so that we can answer your queries at that time. Okay, anything that's in your mind, feel free to ask at the end of the session. But we will discuss our psychiatry mainly today. But any problem with the psychiatry during my lecture, feel free to ask it in here. Okay, in your comment box or in your chat box in the Zoom. So first of all, let me start with the basic thing. Most of you can be just a newcomer here, and you might just want to start your preparation, right? So first thing that you should know that how AMC MCQ works. So AMC MCQ, it has a proper exam format, and most of you should know that this is a computer based adaptive MCQ, which means that you will need to go to a exam center, and then there will be computers in front of you, and then you can start your exam in front of the computer. So it's all computer based, nothing is paper based. There will be 150 question. Out of 150 question, 120 questions will be scored and 30 questions will be non-scored or pilot. But there will be no way you will know which one is scored and which one is non-scored. So it will be all blended. You will get 3.5 hours time to finish this 150 question. And usually, if you want to pass this MCQ, you need to get at least more than equal to 250. Now, this 250 score, there is no known scoring system that AMC usually follows, but like sometimes some of the questions will score 2, some of the question can be 4, 6, even 10 marks. So no one knows that what is the actual score for a particular question. So according to the difficulty level, the scoring differs. So usually they use this AMC scale to show that you passed or failed. So to get your passing score, you have to be in the middle. That means out of 500, you have to get 250. So that's the main thing that you need to know about. AMC CAT exam, they gave this is the topic that you want to know about. So you need to know about medicine, surgery, gynae and ops, pediatrics, psychiatry, and also population health, ethics, biostats, all these will be included in here. They don't usually follow all these percentage. Sometimes some people can get many psychiatry question. Someone can get a very small amount of psychiatry question. Some people can get many questions from pediatrics, and some can get like one or two questions from that. So there is no specific way how the software is going to give you questions. So it's software based. Whatever question you are answering, if it's correct, then the software gives you a little more higher difficulty question. So it goes on in that way. Okay, so some people can get a lot of hard questions, but they can pass more easily because hard questions score is also high. So this works similarly like that. Okay. Now, starting with your psychiatry preparation, for your psychiatry preparation, these are the important materials that you need. So you will obviously need your JM 7th edition. You will need Kaplan Step 2 CK Psychiatry book. You can have it anywhere in online as a PDF. That should be fine. There are good websites which you can search if you are feeling any difficulty, especially solving questions. So usually we used to follow RAND's CP and also sometimes Medscape or eMedicine. Very important for your psychiatry preparation is UWorld USMLE. USMLE is books are why you can wonder why I want to read about the USMLE books. Well, AMC doesn't have specific books on any of their subjects, but USMLE has. And those books are very good. So we will always take some tips. We will try to read those books to get our basics more clear. Okay. Now, UWorld USMLE, it's really important to make your psychiatry preparation very, very crystal clear because it has got a lot of questions and the explanations are pretty good. And most of you did not know much in your medical school or college that about the psychiatry, right? That's most of you, I know. Now, that's why your world USMLE is very important to give you a basic idea about psychiatry. And obviously, we have our own lecture notes, which is very, very well written. You should always stick to these lecture notes, and most of the important things are already given in the notes. Anything which is not given, we will obviously show it to you in our lectures. And also we in our software, when if any of you join in our next course, you will be added to our software, and our software has all these MCQ solved files and explanations and answers and all those questions that you really want to solve. You should obviously go through those files as well. And the usually what you should do, first read the theory from JM Kaplan Step to CK, and then also you already know most about most of these psychiatry things because you already joined our class. So go through these lecture notes, go through those theories. You can also go through the AMC handbook of MCQ, just the psychiatry part. And after that, you go for a question solvation. You can take help from any of the Q bank that is available. We also provide a Q bank for your preparation, so you can always take help from that. And also you should go through this question solvation file at the end, just to make sure that whatever you have read, is it important or not, or is it helping you or not? Okay, so there is lots of talking, I know. This is just the starting because you need to get adapted with my teaching style, and also I need to get adapted with your requirements. And with a combined thing, usually you can learn from me, and I can also learn that what is actually you guys needed. Okay, this is actually how the learning system works. Okay, lots of talking. Now, we will discuss about depression, we will discuss about bipolar disorders, we will discuss about schizophrenia, which are very, very important for your exam. So just before starting, let me inform you that how this is going to work. We will first do the psychiatry theory, and after doing the theory, we will do, like in one class we will try to solve as many questions as possible, the important questions, and then you will get a chance to get into the software to give a mock exam on psychiatry. Okay, so this is how usually our course students prepare themselves. If you ask any of those students in our previous batch, you will know how this works much more easily. Okay, so first theory, then we do subjective question solvation, and then we ask you to go for a mock exam. Starting with the depression. Okay, Now, what is major depressive disorder? This is from your Kaplan. A 70-year-old woman was recently admitted after her son informed the doctor that she had been doing very poorly over the past few months. The patient reports a 30-pound weight loss, decreased concentration, feeling of helplessness and hopelessness, decreased energy, depressed mood, and decreased sleep. Sorry, sorry to bother. Someone's video is on. Can you please stop your video? And also, I can see your name is Administrator's iPhone. Can you please write your own name so that we know who you are? All right, sorry for that. Okay, please make sure that you guys don't start your video. Okay, make sure that the video is always off. Okay, because everyone can see you. Like, that's really not a good idea. Okay, so we've been discussing about the major depression. For major depression, we have a criteria which we need to follow, which is DSM-5 criteria. So for anyone to be diagnosed with major depression, at least 5 of the following symptoms should be there for at least 2 weeks. So what are the symptoms? So you have to look that if this patient is depressed mood or low mood, having a loss of interest, change in weight or appetite, change in sleep, which can be insomnia or hypersomnia, psychomotor agitation or psychomotor retardation. Now, psychomotor agitation means someone can get very restless and agitated in depression, but more common is psychomotor retardation, in which patient becomes more slow. So patient will say that I'm getting pretty slow. So that's psychomotor retardation. Patient can have a loss of energy or fatigue. Feeling of worthlessness or feeling of guilt can be there. There can be loss of concentration. And very, very important thing to look for in any depressed patient, that if this patient having any suicidal ideation. Okay. Now it's hard to remember, but good thing is that we have a mnemonic to remember these symptoms. So which we remember by M size caps, which means M for mood changes, which is low mood or irritable mood. Low mood is more common in adult populations, but irritability is more common in young patients or young adolescent patients. Usually don't show low mood, rather they becomes more irritable in case of depression. They can have sleep changes, S for sleep, I for loss of interest, G for guilty feeling, E for loss of energy, C for lack of concentration, A for change in appetite followed by change in body weight, P for psychomotor retardation or agitation, and S for suicidal ideation. So this is very, very important. Now, among those 9 symptoms, the most two important symptoms which should be there to diagnose someone as depression is A and C, which is mood changes and loss of interest. Okay, at least one of these two should be there in a depressed patient, either low mood or lack of interest or loss of interest. Okay, so one of these 2 should be there. With that, should have at least 4 out of those, out of the rest of the symptoms. Okay, so total 5 out of 9 symptoms, if it is there and it's present for 2 weeks, then you can diagnose this patient with a MDD or major depressive disorder. So the two key criteria for MDD is depressed mood and loss of interest, which should persist for at least 2 weeks. Now, many of you has an idea that to diagnose depression, it should be more than 6 months. No, it's totally wrong. To diagnose someone with the MDD or major depressive disorder, the symptoms should persist for at least 2 weeks. Okay. Now, apart from major depressive disorder, there are also some other depressive disorders. This is from your JM. So patient can have persistent depressive disorder. Patient can have disruptive mood regulation disorder. Some of the patient can have premenstrual dysphoric disorder. These are all part of depression. Okay. Now, what is persistent depressive disorder? Sometimes they give some of the exam questions like this. So remember one thing, that persistent depressive disorder means someone having a long-standing depression of mild severity. Long-standing means at least 2 years or more than 2 years. So someone having a mild depression for at least 2 years or more than 2 years, that patient is having PDD or persistent depressive disorder. Okay. Now, this is not very important. Important is the MDD. Major depressive disorder can have three subtypes: mild, moderate, severe. So it's very important to identify who is having mild to moderate and who is having a severe depression. Okay. And also important to know that in a person with major depressive disorder, what is the worst prognostic factor? Worst prognostic factor, if someone having a major depressive disorder with psychosis, like hallucination, delusion, if those things are there, this patient having a worse prognosis. Some of the MDD patient can have atypical features of depression, which includes increased weight gain, increased appetite, and increased sleep. Most of the typical feature is patient will lose weight, patient will lose appetite, and also will have trouble sleeping. But atypical features means that patient with depression can have increased appetite, increased body weight, and increased sleep as well. These three are important to know because sometimes they can ask you which one is the atypical feature. Okay. Now come to the treatment of depression. Treatment is really vast, but the basic thing you need to remember that when we can start treatment. Now, for someone having a low mood, loss of interest, and fulfilling the criteria of MDD, but not too much severe symptoms. What are severe symptoms? Severe symptoms mainly if someone having a suicidal ideation, that patient obviously having a severe depression. Okay, or if even if they think that they that their life is not worth living, even if they think that what is the point of this life, I just want to end my life, any of this comment in the question, it seems that patient having severe depression. Severe depression patient should be started with medication as early as possible. But in case of mild to moderate, especially in mild depression, patient will have just a milder form of depression, no suicidal thoughts or ideation. They don't think that their life is not worth living. Okay, maybe some low mood, and it's not affecting their life. So that's your mild depression. In mild depression, only thing that you need to do is referring that patient to a psychologist for cognitive behavioral therapy. What is CBT? Cognitive behavioral therapy is a well-known psychotherapy for depression patient in which there will be the psychologist talking with the patient in regards to whatever making this patient depressed or stressed. So they show the patient, they actually try to motivate the patients. They actually want to give them positive thoughts instead of the negative thoughts they are having from their own life experiences. Okay, so that's your CBT. Moderate depression, usually you can start with the CBT, and if that doesn't work, then we go for medication. Severe depression, we will start medication. Sometimes with medication, you can also give psychotherapy or CBT. Which medication we should start? Normally, the best medication is SSRI, which is serotonin reuptake inhibitors. So SSRI is the mainly always we start with. Sometimes we can start with SNRI as well, like Venlafixin or Desvenlafixin. But SSRI is usually our choice of treatment. Previously, people used to give tricyclic antidepressants and also MAO inhibitors. We no longer use this sort of medication because we have a lot of better option nowadays. The last resort will be electroconvulsive therapy or ECT. Usually, if someone is severely depressed, we tried all the medication, did not help, the last option is ECT. We will discuss each of these things later on, don't worry. Before we move into more about the depressions, medication and everything, children having depression is really a tough diagnosis because they don't present like the adults. Adults usually present with typical symptoms, but children or adolescents, they usually do not fulfill the criteria always. So they tend to become more irritated, and they usually have some feeling of worthlessness, feeling of helplessness. These are more common in adolescent. But they can also have loss of interest. They can also have low mood or irritable mood. The basic criteria will be same. That means it should be at least 2 weeks, these symptoms should be there. As you can see in children, irritability may be more prominent than sadness. Apart from that, what are the other signs and symptoms of depression in adolescent? Like someone having difficulty getting to sleep, someone is not enjoying meals, poor concentration, does not want to go to school, always want to be in the room, okay, does not socialize, doesn't have any friends. So all these things can be linked to depression in adolescents. What is the best medication we give for depression in children? Yes, Dr. Abiha, this is from JM. So what is the medication we give in adolescent depression? Anyone? We give SSRI, that's right, but what is the name of the SSRI? So there is a particular SSRI that we usually prefer in case of adolescent. Good, Dr. Basil. Yes, usually we can give fluoxetine or fluvoxamine. Only these two usually the first line one. Now most of the SSRI are same, but in case of adolescent, some of the SSRI can increase suicidal ideation. For that reason, usually if in the exam they ask you what is the preferred antidepressant for adolescent, always remember it's one of either fluoxetine or fluvoxamine, whichever in the option we will choose that one. No, just this, do not start citalopram or citalopram in adolescent. Always stick with either fluoxetine or fluvoxamine. Okay, cool. What is recurrent brief depression? This is important to know. So recurrent brief depression is like someone having recurrent episodes of depression, but it's very short duration, like it, 3 to 7 days, and it comes like a episode every month. Okay, so it doesn't fulfill the criteria of MDD, which means it doesn't persist for more than 2 weeks, but it comes as a episode with a recurrent attack of depression, but it's always a short duration, 3 to 7 days. In those patients, antidepressants are not effective that much. So the alternative medication that you can give is lithium. For them, lithium is a good medication, and usually you will start your treatment with CBT first. Okay, so you start your treatment with psychotherapy, which is CBT, and if CBT is not helping too much, then you can start this patient with lithium, but do not start antidepressants. So this is a kind of exceptional things when we use lithium in depression. Seasonal affective disorder. Some people feel like more depressed or having low mood in case or in winter times. So that's mainly only during winter time they feel depressed. That is known as seasonal affective disorder. For them, the treatment will be psychotherapy, phototherapy, and lastly SSRI. But usually psychotherapy or phototherapy is all that you need to know. Now, premenstrual dysphoric disorder is a part of this recurrent brief depression. So you can see premenstrual dysphoria may be a factor. So if if you see that when during during or just before the period, if someone having depression kind of symptoms, then you can think about that this is mainly premenstrual dysphoric syndrome, which can be a part of recurrent brief depression. So treatment is same. Okay, usually you will start with CBT in both of those cases. So this is from your JM, the management guideline as I described. So mild, usually you will start with psychological therapy, which is sending the patient to a psychologist for CBT. Moderate depression, start with psychological, then later on antidepressants. And in case of severe, we will start with antidepressants initially. Have a look at this question. What do you think about this question? A 72-year-old man comes to the office due to worsening depression and insomnia since his wife died 7 months ago. The patient experiences lethargy, episodes of tearfulness. He has little interest in socializing. He has attended 3 sessions of psychotherapy. However, the patient continues to feel depressed and now having severe insomnia. He has difficulty falling and staying asleep, frequently lying awake at night thinking about his wife. He also feels guilty about her death. Okay? The patient experienced a moment of severe depression last week in which he briefly thought of suicide. So you can see this patient fulfills all the criteria of major depressive disorder. And this patient obviously having severe depression because of suicidal ideation. So he said, there is nothing left for me in this world. Okay. Physical examination shows patient had a weight loss as well. Which of the following is the most appropriate next step in the management of this patient? So what do you want to prescribe to this patient? Obviously, this patient having severe depression, only psychotherapy will not help. So this patient will need some medication. So which medication you are going to start in here? So do not start with electroconvulsive therapy at first. They're asking you what is the most appropriate next step. You have to understand the term of MCQ questions. If in the exam question they ask most appropriate next, that means that they're just asking you that what is the next step. Most appropriate next means next step. Someone just had a psychotherapy for severe depression. You are just not jumping to ECT. ECT is the last resort. Okay, so you will obviously try some medication first. So which medication you want to try? You want to increase the frequency of psychotherapy session? No. You want to prescribe amitriptyline? What is amitriptyline? It's a tricyclic antidepressant. As I said, we don't start someone with amitriptyline or any TCA nowadays. So cross that, cross that. You can also cross ECT because it's not our next step. Provide reassurance and continue psychotherapy. Well, this patient having severe depression, you cannot just reassure and continue psychotherapy. This patient needs medication. So cross that. Now you have only C and D. See that how I am excluding options. This is really important so that you can just concentrate on like one, mainly two options. Usually in the exam, you will always be confused with two options. Okay, so exclude all other things. So you want to prescribe mirtazapine or you want to prescribe zolpidem for insomnia. Now remember one thing, this patient is not having insomnia only, this patient having depression. Zolpidem can be given in some patient having severe insomnia, but very short period of time. And usually you will start with sleep hygiene technique first, followed by some of the medication. But never ever just start someone with a sleeping difficulty with zolpidem or any diazepam or temazepam or any benzodiazepines. So you can obviously cross that out. This patient needs a antidepressant. Mirtazapine is a antidepressant. Although it's not a SSRI, but mirtazapine is a very good drug in someone having severe depression with severe insomnia. Why? Because mirtazapine causes over sedation. So if someone having insomnia, if you give mirtazapine, their sleep will get better. Okay, so that's why it's important. Now, yes, very good question, Dr. Abdul. I really appreciate. So can we also think about grief here? Normal grief should not be more than 6 months. 6 months is usually the maximum time when we say that it could be grief. Now, grief should not affect someone's life in this way. This patient having suicidal thoughts. Grief usually doesn't come in that way. Patient feels guilty, that's okay. Patient don't want to suicide. Patient don't usually lose body weight. These are not a part of grief. But this patient having features of MDD, and that's why you say that they have already given that is 7 months ago patient wife has been dead. So it's already the grief phase should pass after 6 months. Okay, so don't think about grief here. No, see that patient can have suicidal thought, but this patient, if you look at here, that however, he asserts adamantly that he would never act on these thoughts. So this patient doesn't have any active plan at the moment that he's just going to go for suicide. Someone just tried suicidal attempt, okay, or someone has a specific plan, then we can think about ECT. But in the exam, do not think about ECT as your next option. In Australia, we always go for a stepwise approach, which means that start with the psychotherapy in mild or moderate. In severe, start with the medication. Medication doesn't help, go for ECT. But there are some indication of ECT. We will go through that just in few minutes. And it's a very good question that yes, medication can take some time, but this patient doesn't want to suicide actively at the moment. We still have some time. So one of the very important part of psychiatry is psychological pharmacy. Okay, this psychiatry is more about the side effects because many of these medications can cause a lot of side effects. So you should really know the common side effects of these medications. Like SSRI can cause insomnia. It can cause sedation sometimes. Your appetite can be changed. You can have nausea, dry mouth, headache, and sexual dysfunction. The question that is important for SSRI side effects is that if you go into your AMC handbook, you will find a question related to SSRI side effect that you started someone with sertraline, which is a SSRI, and after a few weeks, this patient started to have abdominal pain and some kind of nausea and GIT side effects mainly. So he's having abdominal pain and nausea. Now, if someone develop side effects from SSRI, especially GIT related side effect, the next best option is changing to another medication of the same group, which means that you started with sertraline. Now you can try with another SSRI, like you can try with fluoxetine, paroxetine. Okay, so any of the other SSRI you can try. So change it to another drug, but in the same group. Do not go for any other group, like do not start TCA, MAO inhibitors, or SNRI. Okay, so same group. That's for GIT side effect. But if someone having sexual dysfunction, like you started a patient with 100 milligram of sertraline, and like 3 4 weeks later patient came back to you because this patient started to have erectile dysfunction. Very important case for the exam as well. What you want to do for this patient? So the stepwise approach in that particular situation will be, first you can reduce the dose of sertraline if 100 milligram sertraline is helping the patient. That means patient's feeling better at the moment. The depression is very big, like depression has been improved after starting the medication. So you can give a trial of reducing the dose. So usually if you give 100 milligram sertraline, you can reduce to 50 milligram. So one of the choice will be reduce the dose. The second option, which is more important, like you can change to another group, not SSRI. You can try some other group, like you can try some SNRI. More better that some of the antidepressants are there which doesn't cause too much sexual dysfunction. Like you can give metazapine. Okay, so another option will be switching the SSRI or switching the medication to another group. And last option will be you can add sildenafil, which is Viagra. So you can add sildenafil to help the patient with the erectile dysfunction. But that's the last option. You should first try these things first. In very rare moment, like in 10% cases, even with just wait and watch approach can help. But it's just 10%. Most of the patient will not get better. So usually we keep in these three options. First, reduce the dose if we can, then changing to another group of medication, or adding sildenafil. Okay, so that's our option. Very important to remember that. So I have given all the side effects of this medication. Give it a look. Okay, so you can see that most of these usually will cause headache, insomnia, anxiety, drowsiness. Okay, give it a read. Metrazapine side effects. It's important to know some of the other group side effects also. Metrazapine, mainly you should know that this metrazapine can cause severe sedation and it can also cause weight gain. Okay, so that's why it's important to remember only these two are important, others are not very important. There is another medication which we use very frequently. that is venlafaxine or desvenlafaxine, which is a part of SNRI. Now, venlafaxine, desvenlafaxine has a very good effect on some of the patients, but it has some side effects which you should always remember. So, the most important one is that it can increase blood pressure. So, you cannot give venlafaxine or desvenlafaxine in someone having hypertension. Okay. If someone have a history of epilepsy or seizure, you cannot give it to them because this can lower down the threshold of seizure in this patient. All right. And this can also cause hyponatremia. So if you get a question that this patient, like a 60-year-old patient coming to you for acute confusion, you did all the blood tests. One of the blood tests showed that patient having hyponatremia, like sodium 120. And you just notice that this patient is on venlafaxine. So you should always think that venlafaxine can be a causative factor. So always stop venlafaxine or reduce the dose and then stop gradually. Okay, so very important that this can cause hyponatremia in mainly elderly patients. And these are also some of the common side effects. Venlafaxine causes insomnia rather than sedation. All clear, guys? Any questions so far? You guys are understanding me? Good. Okay, let's move on. So, serotonin syndrome. So, what next if patient partially improve despite SSRI? Now, it's a vague thing actually. Like, patient, if someone is if someone partially improved, they usually want to continue the medication. And like, there is no like, I am depressed. It's always like that. Is this patient depressed or not depressed? If depressed, is it a low, is it mild, moderate, or severe? So this thing always be like that way. If someone said no, I'm not sure that I'm depressed or not, then you just need to think that it could be just a low depression or like a mild depression, or patient is totally fine. Okay, it we like usually in the exam they will not give you something like like this much confusing. And some patient may even get better even without SSRI. Yeah, we'll go into that. Like if someone doesn't get fully improved, then what we will do. All right, don't worry. We are just going into that. Okay, serotonin syndrome. It's really an important side effect of SSRI that you should always remember. If you start someone with a SSRI and that patient somehow getting another serotonin containing medication, it can be another SSRI, another GP has given, and you have given another SSRI. So now patient taking two SSRI, that's very commonly can happen. That means patient is increased risk of developing serotonin syndrome. The second, some other medication can also increase serotonin like any other antidepressant. If you give SSRI with TCA or MAO inhibitors that always increase serotonin, very commonly asked in the exam is that if someone is on serotonin containing drug like let's say fluoxetine, and you have given tramadol for pain, this patient can get serotonin syndrome. It's very commonly asked question. So tramadol can increase serotonin in your body. Some of the stimulant drug like MDMA, Stacy, okay, or amphetamine, this can also increase serotonin. Lithium can do that, and antiemetic medication can also do that. So these are the medications. If you combinedly, if you prescribe to a patient, then they are having an increased risk of developing serotonin syndrome. So what are the criteria of serotonin syndrome? Patient can have altered mental status, patient can have altered muscle tone, and some neurological or autonomic instability. Mental status, mainly patient can have agitation, confusion. Even sometimes this patient can have convulsion or coma. In case of neurological finding, patient can have hyperreflexia, patient can have tremor, and also myoclonus. So usually patient will get hypertonic, hyperreflexia, tremor. Some of the patient can even get very high fever with increased sweating. In autonomic instability, patient will get hypertension mainly. Patient can get tachycardia as well. Okay, so the most important finding that you need to remember that if this patient taking medications which can increase serotonin, the second thing, what is the sign and symptoms? Is this patient having high fever, sweating, tremor, hypertension, tachycardia, and you did some neurological test and you found this patient having clonus, hyperreflexia, so most likely this patient having serotonin syndrome. Anyone having a suspected serotonin syndrome, you should immediately stop the medications which can increase serotonin. So the offending medication should be withdrawn immediately. Okay, and then you should always refer this patient to the emergency department. Now sometimes some of the patient can have severe serotonin syndrome. That time you can also prescribe cyproheptadine. It can antagonize the effect of serotonin sometimes. So in case of severe serotonin syndrome, you can try cyproheptadine as well. So you can look at this patient. This patient is actually all the manifestation of serotonin syndrome. This patient can have mydriasis like dilated pupil, can have increased sweating, tachycardia, hypertension or hypotension, can have even diarrhea, clonus, tremor, hyperreflexia. Now, you can get confused with serotonin syndrome and neuroleptic malignant syndrome. So, serotonin syndrome is actually a complication of serotonin containing medication, whereas neuroleptic malignant syndrome is a complication of antipsychotic medication, like what the medication that you prescribe for schizophrenia. Okay. Now, how to differentiate between these two? Obviously, you should see that what type of medication this patient is on. Then, serotonin syndrome onset is usually very abrupt. In neuroleptic malignant syndrome, it's gradual. The neuromuscular finding is very, very prominent. You will get myoclonus and tremor in serotonin syndrome. And in case of neuroleptic malignant syndrome, patient usually present with muscular rigidity. So it's more rigidity in neuroleptic malignant syndrome, whereas hyperreflexia, tremor, clonus, these are more common in serotonin syndrome. So in serotonin syndrome, reflex will be increased, but in neuroleptic malignant syndrome, it will be decreased. So these two will help you to diagnose mainly. And if you look at the pupil, there will be dilated pupil in SS and normal in NMS. Okay. And also, yes, very good that sometimes in case of neuroleptic malignant syndrome, you can get increased creatinine kinase. Now, even in serotonin syndrome, you can get it if someone having like too much myoclonus, Then sometimes you can even get CK raised in serotonin syndrome, but it's more prominent in neuroleptic malignant syndrome. Okay, so that's mainly the serotonin syndrome that you need to know. So first management is to stop the offending drug. Now, let's say that you started medication in a patient and patient has achieved remission, which means patient is feeling totally better after starting the antidepressant. It is recommended to continue the antidepressant medication for at least 12 months for initial episode and at least 2 to 3 years in subsequent episode. All right. So remember that it's very commonly asked in the exam. So 12 months for initial episodes, 2 to 3 years for subsequent episode. And some of the risk factor of relapse are here. Give it a read. It can come in the exam. Not very, very important. I was going to your Kaplan step to CK. If you open your your JM 7th of edition, so in chapter 19, there is depression. Give it a read, obviously. But if you come to page 183, so in here, they have written everything about the drugs that you can use. You can give it a read. We already described everything. Just this one, you should have a look that when using antidepressant, if a response is not evident in the first 2 weeks, so there is no response in first 2 weeks or inadequate response in 6 weeks, it's very unlikely that the medication that you have given, it will work. So usually it is recommended to change the medication. So you can try another SSRI or you can try another group like SNRI, Venlafixin, Venlafixin. But if remission is not achieved in 3 months, then consider a second opinion. But important is this line that if someone hasn't got any effect in first 2 weeks or just a partial effect in 6 weeks, you need to change the medication. Now let's say you've got such a patient and you want to change the medication. Can you just stop the medication that you have given and then change to other or restart a new medication next day? Can we do that? No, we cannot do that. It's because of what? Because even after you stop antidepressant, sometimes in the blood, it can be present for even up to 7 to 14 days. And that's why the term washout period will be used. What is washout period? So you need the body to excrete those antidepressant in the blood. So usually it depends on medication to medication. So usually fluoxetine we can give a 7 days of washout period. Some of the medication just 1 day washout period. So depending on that, we usually keep it as a like 3 to 7 days or 4 to 7 days. Okay, so we will keep no medication in this period and then we will start another medication and always gradually stop or gradually reduce the dose of the antidepressant that you have started and then stop. Give it a washout period for 3 to 7 days and then restart another new medication. What will happen if you stopped a medication today and you restarted another SSRI tomorrow or just today? What can happen? Serotonin syndrome, right? Because this patient still will have enough serotonin in the blood. So that's why it's very important to make sure you guys know about this washout period. The last option for any patients who has got enough treatment, enough medication is your ECT, electroconvulsive therapy. It's mainly used in case of severe or resistant depression. There are some side effects like patient can get long-term memory impairment. What are the main indication of ECT? If someone having psychotic depression, that means depression with psychosis, again remember, you will always start with medication first, then try ECT. Someone having melancholic depression, unresponsive to any antidepressant. So melancholic is like patient is very, very severely depressed, very low, and even sometimes they can have total mute. So they're not even talking with anyone, not eating and drinking. So just stopped everything. So that case in melancholic depression, even if you're trying the antidepressant, patient is not even taking any antidepressant, then this is one of the important indication for ECT. Okay, so refusal to eat or drink, that's one of the important things that come in the exam sometimes. Now remember one thing, there is an important thing that you need to learn about ECT, that let's say that in the question they are asking that there is a patient with severe melancholic depression and patient stopped eating and drinking totally, and on your examination you have found that this patient having dehydration. Patient is unable to give consent for ECT. What you are going to do now? Okay, let's say that patient even doesn't want to go for ECT, but patient having severe depression, obviously patient doesn't have any capacity to give this consent. What you can do for this patient? Now, the thing is that you need to have a look in the question that if this patient is having severe dehydration and patient is stopped taking any food, no drink, nothing, at that time, you can go for ECT under duty of care, which means that you don't need any consent. If you feel that this is the best treatment for this patient, you can go for it, even without any consent from anyone. But if you are not sure that, well, what I should do, then you should always take the consent from the tribunal. Tribunal doesn't take too much time to give you consent, so you should always try to go for a tribunal if patient is stable. If in the question they say that patient is having severe dehydration, patient is not taking anything, then you can even go for ECT without even going for tribunal. So it's just a duty of care management, you can go for it. But in the question, if nothing such mentioned, then you should go for a mental health tribunal. Yeah, so go for mental health tribunal if it's not life-threatening situation. All right. Yes, Dr. Nahar. So if in the question they say that patient refusing food and drink, but patient is stable, you should always go for mental health tribunal. Good. So that finished our depression. Any question on depression? I think that if you know this much, there is nothing, no question can can be there actually. Everything should be covered with this discussion. Okay, you will see when we discuss the questions. All right. So let's take a 10-minute break and then we will go for bipolar disorder and schizophrenia. Okay. So 10-minute break. All right, everyone. So let's just start again. So next topic is bipolar disorder. Bipolar disorder is one of the other affective disorder. So affective disorder means which like interrupts your mood mainly. So in case of bipolar disorder, so in a normal person, let's say that this is the normal mood. Sometimes in bipolar patients, they get really euphoric or they get really good mood and high mood. And sometimes they get into the depressive phase, which is low mood. So bipolar disorder is nothing but a combination of someone having an episode of mania and sometimes having an episode of depression. So when this is the case, like someone having an episode of mania sometimes and sometimes having depression, that's what we call bipolar disorder. It's actually a swing in their moods. First of all, we need to know about mania because we already know about depression. In case of mania, patient should have at least 1 week of abnormally elevated mood. With that, patient should have at least three or more of these features. So what are those? Patient can have increased self-esteem or grandiosity. Patient can have decreased need for sleep, and patient will be very talkative, rapid pressured speech. So all these things will be there. With that, you can also get racing thoughts or flight of ideas. Patient will be quite distracted. Patient can be very loud and talkative. They will be having increased goal directed activity, which means that they will involve themselves in a lot of activities like like a sports club, science club, magazine, thesis, sports. So lots of activities they will do at the same time. And their idea will jump from one topic to another. Okay, they can also have increased sexual drive and reckless driving, lots of gambling, lots of spending of money. So all these are feature of mania. And mania always it impair the social, occupational, and personal life of a patient. So it's easy to remember by using this mnemonic dig first. So D for patient becomes very distracted. I for insomnia, so decreased need for sleeping. G for grandiosity. Patient actually thinks that they are having some superpower or their self-esteem becomes much more inflated than any other time. F for flight of ideas, so they usually have racing of their thoughts, they jump from one topic to another. A for activities, so lots of goal directed activities. S for speech, their speech becomes loud, talkative, and pressured. And T for thoughtlessness, which means the patient will take a lot of risky behavior, so increased sexual drive and lots of unprotected sexual intercourse, financial recklessness, like they will spend a lot of money, okay, reckless driving. So all this is part of mania. Sorry, before that, Thomas, you asked a question. Can you please explain on the initial episode and subsequent episode of serotonin syndrome? There is no initial or subsequent episode of serotonin syndrome. That was actually about initial episode of depression and subsequent episode of depression. So kind of different thing. Initial means that patient diagnosed first time with depression, and subsequent means that patient having relapse of depression. It's not related to serotonin syndrome. All right. So dig first is all about your mania. So you need to find out if this patient having high mood. Along with the high mood, any three of these symptoms, if it persists for more than equal 1 week, that's mania. There is another term called hypomania, which is a milder form of mania, and usually the symptoms persist less than a week. It doesn't impair their social, occupational, or personal life. But symptoms can be totally same. Only the duration and effect of these symptoms on their life will be different in mania and hypomania. Okay, so very important to understand these two. There are two type of bipolar disorder. One is bipolar 1, another is bipolar 2. 19-year-old college student is taken to the school counselor after he fails several classes. The patient is enrolled in numerous classes, most of which have conflicting times. His grades are poor, yet he seems undisturbed by this. He is also enrolled in numerous organizations, chess club, drama club, student government, sports, and at least two other fraternities. His speech is pressured and has psychomotor agitation. Psychomotor agitation means that patient with mania or hypomania, they become really restless. That means you will know this patient having mania. So they have they, they are very talkative, very loud. They are jumping from topic to topic. So you will know that this patient having mania most likely just by looking at them. So what is bipolar 1 disorder? So a mood disturbance in which patient typically experiences symptoms of elevated mood for at least 1 week that cause significant distress in his or her level of functioning. So bipolar 1 disorder has one fully fledged manic episode with depressive episode. So bipolar 1 means someone having like lots of depressive episode, but patient had a fully fledged manic episode at least once in their life. That patient having bipolar 1 disorder. Now someone having major depressive episodes but having hypomanic episode, not a classic mania, they are bipolar 2 disorder. So only difference is that if someone having mania with depression, that's bipolar 1. Someone having hypomania with depression, that's bipolar 2. So give it a read about what are the other features of a mania patient. So all I have discussed, these are very important. They will give this in the question and you need to understand this patient having mania or hypomania. So hypomania usually persists not more than 4 days. And it's a minor form of or milder form of mania. Now, very important to diagnose mania and then treat mania patient. This is a medical emergency, so this patient needs to be hospitalized. Every patient of acute mania should be referred to the hospital for admission, even if it is an involuntary admission, which means that if patient doesn't want to be admitted, you can involuntarily admit this patient. The most appropriate medication to start with in case of acute mania is antipsychotic medication. Okay, this is the most effective one. So what is the first line? Usually you can start with any of the antipsychotic, which is second generation, like you olanzapine or risperidone. Usually you will, if in the question there is olanzapine or risperidone, you will choose any of these two. Then if in the option there is no olanzapine, risperidone or any other antipsychotics, like which is second generation, you can go for the first generation like haloperidol. You can try another second generation, which is aripiprazole. You can try lithium as well, but usually for acute mania, we don't give lithium unless there is no other option. There are some of the other mood stabilizing agents like sodium valproate or carbamazepine. Just keep this medication name in your mind because sometimes they might not give olanzapine risperidone in the option. Then you need to choose haloperidol, lithium, sodium valproate or carbamazepine. Now, if some patient with mania, they become really aggressive and agitated that you cannot give them oral medication, then you can also give IV or IM haloperidol. It's only for patients who are having active violence or aggression. But normally olanzapine, risperidone will be your first line choice. So that's for acute mania. Now, if someone having recurrent episodes of bipolar disorder, at least 2 or more episodes of bipolar disorder in the previous 4 years, that patient should be started with a prophylactic medication to stabilize their mood. Usually, for prophylaxis, we use lithium. So you will start lithium. Sometimes you can use some second generation antipsychotics or even some mood stabilizer like valproate or carbamazepine. But best prophylaxis will be lithium. Use long-term lithium like 3 to 5 years just to make sure patient get stable. Now, someone on lithium, you need to make sure that this patient is not developing lithium toxicity, which is very important complication. So usually always you check the lithium level 3 to 6 monthly. The normal is zero point 0.6 to zero point 0.8. Someone having a possibility of lithium toxicity can present in many ways. Usually they can present with mild GIT upset like nausea, vomiting, or even sometimes just abdominal pain. Some patient can present to you with tremor, hyperreflexia, agitation. Some patient can have muscular rigidity or hypertonia as well. And lastly, this patient can get cardiovascular collapse like severe hypotension or severe CNS toxicity like seizure, coma, etc. Now, the treatment of lithium toxicity is important. Most of the lithium toxic patient usually dehydrated. So your first line medication or first line management should be making sure that patient get IV normal saline. So make them hydrated first. But only in case someone having kidney failure, cardiovascular collapse, or severe CNS toxicity like convulsion, coma, only these are the 3 indications in which you should start dialysis. Apart from that, you can only make sure patient is hydrated and symptomatic management is all that you need to do. People with long-term lithium, they should be also tested for thyroids. So because lithium can cause hypothyroidism. Okay, so someone on lithium for bipolar disorder coming to you with tremor, shaking, nausea, vomiting, and you have found out hyperreflexia, rigidity, you think about lithium toxicity. So you do a lithium level at that time and start treating those patients. Usually, even sometimes lithium level can be normal, but patient can have toxicity. So symptom is very important. If you see that patient is having severe hypertension, having kidney failure, or having seizure or convulsion or coma, you should start with dialysis. But if that is not there, then just IV fluid. Now, management of bipolar depression. So you know how to manage acute mania. You know the prophylaxis of mania patients. Now, some of the times what happen that patient can present to you with depression. Okay, so patient can present to you with depression, and you started that patient with some antidepressant. After starting that antidepressant, patient can have mania episode. So what happens is that in case of bipolar depression patient, if you start with only antidepressant, that can precipitate the attack of mania. So it's not your fault, okay, but it can happen many times. Now if you know that already this patient having a bipolar disorder, now patient having depressive episode of bipolar, what you should do, that's the question. So always start them with antidepressant plus some mood stabilizers. Okay, don't just start them with antidepressant. So you will start with SSRI plus you can give any of these like lithium, valproate, carbamazepine, lamotrigine, olanzapine, any of these you can do. Better to give some mood stabilizer like lithium valproate rather than starting with olanzapine. Okay, so because you are giving it as a prophylaxis, so better to give any of these three. Clear, guys? So always remember, anyone having bipolar depression, you will always treat with these two, not just antidepressant. Let's solve this question. 27-year-old man is brought to the office by his wife due to her concerns that he has not been himself for the past 3 weeks. She says that he is depressed and withdrawn, sleeps 14 hours a day, has no energy or interest in looking for work or participating in any activities. Patient was hospitalized 6 months ago for an episode in which he became aggressive toward his wife. That occurred when she confronted him about staying up all night, gambling, investing a large amount of money, and then later on went bankrupt. He also spoke very rapidly at that time, and he had brilliant plan to achieve world peace at that time. So what is this episode at that time? He also experienced a similar episode 2 years ago and improved and discontinued treatment shortly after. Which of the following medication are the most appropriate for maintenance treatment of this patient? So now you have found a patient who is depressed now, but previously had a mania attack. So this is a bipolar patient, right? So what is the best treatment for this patient? You want to give carbamazepine, fluoxetine. You want to give lithium quetiapine, lithium sertraline. Do not choose anything you don't know, like lurasidone or risperidone. Clozapine is the last resort of antipsychotics, so forget about it. Valproate, haloperidol. Haloperidol usually you don't use unless needed. Now you need to give one mood stabilizers and one antidepressant. So you look for that. So you have got fluoxetine, which is a SSRI. You have got carbamazepine, which is a mood stabilizer. So it's a good option. You have got antipsychotic and lithium. So these both are actually for mania. So nothing is for depression. So rule that out. You have got lithium and sertraline. So out of A and C, which one you want to use? So lithium and sertraline, that's also a good option. Carbamazepine, fluoxetine, also a good options. I would obviously choose lithium first because that's a that's the best for prophylaxis or maintenance. So see that sometimes you can get two and like two options which could be the answer, but then you need to choose the best option. So that's very, very important to understand. All right. So we are just at the finish of bipolar. So there is a term called persistent depressive disorder. We already discussed that if someone having depressed mood that's presenting most of the days for at least 2 years, that's called persistent depressive disorder, or there is another name, dysthymia. Usually your treatment should include like a psychotherapy or CBT. Okay, and if that doesn't help, then you can go for some medication. There is another term called cyclothymic disorder. This term is important. Cyclothymic disorder, if you look at here, it's a chronic disorder characterized by many periods of depressed mood and many periods of hypomanic mood for at least 2 years. So if you say that dysthymic disorder or dysthymia is mainly having a low mood or depressed mood for at least 2 years, whereas cyclothymic disorder is a, you can say, mild bipolar disorder for 2 years, which means patient having some periods of depression, some periods of hypomania, persistent for at least 2 years. That is your cyclothymic disorder. For those patients also, it's a good idea to give a long-term prophylaxis of mood stabilizers like lithium, carbamazepine, or valproate. So you can have a look that Mrs. McDonald has experienced 12-year history of periods of feeling great followed by periods of feeling lousy. During her feeling great periods, she experienced increased sexual drive, euphoria, and increased irritability. During her feeling lousy, she experienced insomnia, fatigue, and low self-esteem. So this is your cyclothymic disorder. Very important at least to know what is these disorders are. So Dr. Roy, what can we choose for acute management? So for acute mania, you should always choose antipsychotic. You don't choose lithium for acute management. Lithium is for a chronic maintenance treatment. In case of depression, there is a term called grief or bereavement. You should always know how to differentiate between grief or bereavement and depression. Usually, someone can lose their partner, their close friends or relatives, and they can have feeling of low mood, crying, and like most of the depression features they can also have. But grief or bereavement should go away in 6 month time. All right. Patient with grief usually doesn't have suicidal ideation, and their symptoms are not persistent. It just like walks and wane, something like that. And patient usually return to their baseline within 2-3 months. But keep in your mind that someone has lost very close one, having features of depression like sadness, tearfulness, sleeping difficulty, loss of appetite. So all these features, but if it persists up to 6 months, that's fine. You can just do some cognitive behavioral therapy for this time period, just as a brief or grief or bereavement. But if it persists beyond 6 months, okay, that becomes a complicated bereavement or complicated grief. Okay, but some of the patient can get full measure criteria of depression. If measure criteria, that means if the criteria of MDD fulfills, then you should always diagnose this patient with depression. That means that someone lost their dearest one or someone lost their closest one, they will always have only grief. That's not like that. They can also have features of major depressive disorder. So you should always look at the criteria. If they fulfill the criteria, then you diagnose them as depression. But in the exam, usually if they say that they lost someone sorry, or partner has died, or like 6 months ago or 3 months ago, you should think about grief first. So three things I said. One is normal grief, which can be up to 6 months. After 6 months, patient is still having features of grief, that's complicated grief. There is another term which is depression. If patient fulfills the criteria of MDD, then you will diagnose them as depression. Okay. No. So what is BP2, Dr. Afrasiab? Bipolar 2. Okay. Yeah. The difference of duration between bipolar 2 and cyclothymic disorder. That's correct. If someone like bipolar 2 disorder doesn't have any specific duration. Okay. Cyclothymic disorder means that someone having many depressive episodes, many hypomanic episodes, but that's going on for at least 2 years time. Then you can only diagnose them as cyclothymic disorder. All right. What's the answer of this question? A 50-year-old woman is taken to the hospital after neighbors find her wandering in the streets, mumbling to herself and gesturing. When approached, she begins to cry and expresses thoughts about hurting herself. Examination reveals a scratch mark on both her forearms and also questionable lacerations on her throat. When questioned, she reports feeling depressed since her husband died 5 months ago. She reports a decrease in concentration, feeling of helplessness, hopelessness, anhedonia, also lost her job. She now has begun to hear her husband's voice asking her to join him. What is the next best step for this patient? So begin a trial of antidepressant, refer to psychiatry, refer for ECT, assess for thoughts about suicide, and refer to the outpatient department for follow-up. You should always assess first that this patient having a scratch mark, this patient having questionable laceration. So first thing that you do is assess the thoughts about suicide. So remember one thing, before doing anything, if there is an option of explaining, assessment, these are always the best choice. So assess her about the thoughts of suicide, then you can refer the patient for treatment or even electroconvulsive therapy if needed. For this sort of patient, ECT will be a good option later on. Okay, but this patient needs to go to the hospital, needs to be admitted in the hospital, then treatment will start. All right. So did you guys understand about depression and bipolar disorder? Any questions so far? Those who are in the Facebook, you guys have any questions so far? Good. Let's move on. The next topic that we are going to do is schizophrenia. Now, schizophrenia is really important for your exam. We might not be able to finish the whole topic today, okay, but we will try our best. So, what is schizophrenia? schizophrenia is a thought disorder in which patient actually lack or lose their touch of reality, or in a simple way, that it's a thought disorder in which patient is unable to interpret what is their reality. So they have some thought disorders, they have some positive thoughts and negative thoughts. Okay, so they can have hallucinations, delusions, they can have disorganized speech or behavior. Some of the patient can have some negative symptoms as well. We will discuss all these things. Now, schizophrenia, usual age of onset is 15 to 25. It has some association with familial or like familial tendency, I would say. So general population, it has a prevalence of 1%, monozygotic twin 47%, dizygotic twin 12%. Now this prevalence is very important. It comes frequently. If one is schizophrenic patient, 12% chance that their children can be schizophrenic. Two schizophrenic parents, 40% chance. First degree relative, 12%. Second degree relative, 5 to 6%. Very important to remember about second degree relative. Sometimes they can ask that, like, grandmother had schizophrenia, what is the chance of schizophrenia for this patient? So remember, 5 to 6%. Now, to diagnose schizophrenia, you need at least one of these three. Okay, so patient should have delusion or hallucination or disorganized speech. At least one of these three should be there. With that, two or more of the following, which means that patient can have grossly disorganized behavior. Patient can have some negative symptoms like flat affect, total withdrawal from society, lack of emotion. So these are negative symptoms. Okay, to diagnose schizophrenia, these symptoms should be there for at least 6 months. That's very, very important. Now, sometimes these symptoms can be a manifestation of drug abuse, like someone abusing marijuana, someone abusing some of the other illicit drugs can have similar presentation. So always you need to rule out any substance abuse before you diagnose schizophrenia. So what is delusions? Delusion means kind of abnormal belief, which patient believe absolutely, even after if you show that this is very unlikely to happen. So it's a kind of bizarre delusion. Like if someone think that they're having worm in their brain, okay, that's one of the delusion. Someone someone believes that they can their soul is different from their body and they can see their soul. So this is a kind of delusion, kind of bizarre delusion, which is very unlikely to happen. Sometimes you can get delusional disorder, which means that patient only have abnormal belief, but that's not bizarre. This can happen somehow. Okay, like if someone thinking that like his wife is trying to poison him, but no other hallucination, no disorganized speech. He's a professor even in one of the university. So that's only delusional disorder, not schizophrenia. So there is difference of delusion which we need to understand. So delusion, then hallucination. Hallucination is kind of abnormal perception. Like you can have visual hallucination, like if patients see someone, or if patients see there is lots of cockroach on the table, but there is not anything. So if someone having abnormal visual perception, that's visual hallucination. Sometimes patient can say that they can hear someone talking, okay, or they can hear some voices. That's auditory hallucination. Some people can feel that something is like always there in their body, like someone saying they can feel insects are crawling on their body, but actually there is nothing. That's tactile hallucination. So these are all important things to understand. So you will get delusion or hallucination or disorganized speech. Disorganized speech means whatever patient is saying, there's total nonsense and bullshit. You can't even understand what they're saying. Okay. So at least one of these three should be there. With that, patient should have disorganized behavior or some negative symptoms like flat affect, withdrawal from everyone, not going to anywhere, like total social withdrawal, lack of emotion. That's your negative symptoms. And that should persist for at least 6 months to diagnose it as schizophrenia. So you can see these are the positive features and these are the negative features. Why these are called positive? Actually, positive means these are extra symptoms for a schizophrenia patient which a normal person should not have. And negative means that a normal person should have that, but the schizophrenia patient doesn't have it. So positive features are delusion, hallucination, thought disorder, and disorganized speech and behavior. Negative or flat affect, thought like poverty of thought, lack of motivation, social withdrawal, reduced speech output. Just remember these features because sometimes they can ask it. These are the drugs which can present with drug-induced psychosis like amphetamines, hallucinogens like LSD and marijuana. Okay, now management. Someone having schizophrenia, management is really important. You need to start them with some antipsychotic medication. So what is the initial medication that you should start with? Usually you will start with atypical antipsychotic, which is better, which is your either olanzapine or risperidone. So this is your initial oral therapy for schizophrenia patient. Excuse me, sorry for that. Now, if response is inadequate in 3 weeks, you should increase the dose according to the guidelines. If no response after 4 to 6 weeks, then consider a change to another second generation. Like there are lots of second generation you can choose from, but olanzapine, risperidone, aripiprazole, quetiapine, these are mainly prescribed. If you tried those second generation not helping, then you can try some first generation. In first generation, usually you can use haloperidol, but usually we don't use chlorpromazine, trifluperazine. These are no longer used nowadays. If someone is like really agitated and violent and psychotic, that patient will need some IM or IV. Usually you can give some IM haloperidol for those patients. If IM haloperidol is not available, then you can also try olanzapine IM. Okay. So this is important. Normally you will start someone with oral antipsychotic, usually olanzapine or risperidone. But if some patient having active psychosis and like being violent and aggressive, then oral medication will not help. You will just give a IM haloperidol or IM olanzapine. Now, some of the patient can like usually this medication takes some time to give you a stable response. So usually 2 to 4 months, usually this medication needs to give a stable response. Now, some patient can have drug-resistant schizophrenia, which means that you have tried 3 antipsychotic medication at their maximum dose, but still it's not helping the patient. That's known as drug-resistant schizo. For those patients, you can consider a trial of clozapine. Now, clozapine is usually we don't want to start anyone with because it has like severe side effects, but it is the most effective medication also. But because of its side effect profile, usually we don't want to use that. But that's our last resort of antipsychotic. Okay. Now, clozapine, because why we don't use it, it can cause blood dyscrasia. That means you can get some of the, like, you can get agranulocytosis, you can get mainly cardiotoxicity. So that's one of the very important thing. Someone on clozapine having chest pain, you should always think about cardiotoxicity. So you should do a ECG and troponin immediately. Okay. Now, if clozapine is still not helping, the last option will be electroconvulsive therapy. All right, guys, clear? And someone on clozapine, how we usually monitor those patients, you do like some initially monthly and then 3 to 6 monthly, you will check full blood count, looking for any blood related problem. And also you can do like ECG and troponin if needed only. Okay, next. The medication, the antipsychotic medication is notorious to cause side effects. So what are the common side effects it can have? One of the most important one is acute dystonia. In acute dystonia, patients usually have kind of bizarre muscle spasm of their face, neck, tongue. So patient will come to you that they're having involuntary spasm of their facial muscles. So that's your acute dystonia. It's common after starting the treatment. So you can just give them benztropine IV or IM. That should help. Next is akathisia. In akathisia, patient feel a subjective restlessness of foot and legs. You will notice that patient is frequently moving their foot and legs involuntarily. Okay, but it usually develops later in the course of treatment. That means after a few months or even years. In akathisia, you can start with reduction of the dose, or if that doesn't help, you can give oral propranolol, diazepam, or benztropine as a short-term measure. Okay, so try reduce the dose first and then using any of these three. Next is Parkinsonism. Patient with mainly typical antipsychotic like haloperidol, chlorpromazine, or even risperidone, patient can develop Parkinsonism kind of features. Like patient can have gait problem like Parkinsonism. They can have muscle rigidity. Okay, they can be very slow. So all the Parkinson-like features can be there. In that situation, you can lower down the dose, or you can alternatively use benztropine or benzhexol. Okay. There is another complication called Tardive Dyskinesia, in which patient will have abnormal movement. It's not spasm, remember. Spasm is dystonia. Abnormal movement of face, mouth, tongue, and limbs. So usually you will see that patient having like kind of shivering or tremor of their limb, tremor of their face, mouth, kind of fasciculation. Okay, so you will see that patient having involuntary movement of their facial structures. It's very prominent on the tongue as well. If you see the tongue, you will see tongue is moving frequently. Usually happens after long-term antipsychotic drugs, even months or years. So for those, you usually you should stop the medication gradually. Even after stopping, patient might have it. So you can use tetrabenazine for those patients. Okay, so if drug withdrawal is ineffective, use tetrabenazine daily. And last one is the neuroleptic malignant syndrome, which we already discussed. Now, it can develop any time during your starting of this medication. Patient can have high fever, muscle rigidity, altered consciousness. You have to stop the medication immediately. Make sure patient is well hydrated. In case of severe form, you can give bromocriptine or dantrolene. Okay, you need to remember this medication name because it frequently comes in the exams. Now, side effects of antipsychotics. We have been discussing that, but the most important questions that comes from schizophrenia is from this chart. So look at these. These are the all second generation antipsychotics. If you look at here, we will only know about important one: aripiprazole, clozapine, olanzapine, quetiapine, and risperidone. These are your important antipsychotics which are frequently used. Now look at olanzapine. Olanzapine mainly increases your chances of metabolic syndrome, which means that it can increase your weight. So if you look at here, so weight gain is very prominent in olanzapine. It is also kind of like highly sedative drug. It can increase your glucose, so hyperglycemia or diabetes. It can cause dyslipidemia as well. So olanzapine and clozapine, their side effects is pretty same. So clozapine also causes dyslipidemia, hyperglycemia. It's very, very sedative and also weight gain. Okay. Now have a look at the quetiapine. Quetiapine also causes dyslipidemia, hyperglycemia, sedation, and weight gain. So these three are pretty same side effects. Now you see that it's easy to remember, right? Now risperidone, its main side effects is hyperprolactinemia, which means it can cause galacturia, or you can see that some patient having like whitish discharge or like mainly whitish discharge from their nipple. So galacturia can be a presentation for hyperprolactinemia. And that's one of the very commonly asked question. It can also cause orthostatic hypotension. And among all the second generation, this one has a greater chance of causing extrapyramidal side effects, which is like Parkinsonism or any other extrapyramidal side effects you have already seen. These are all extrapyramidal side effects. Okay. Now, someone using risperidone coming to you with galacturia, what you can do for them? Look at aripiprazole. It doesn't have any hyperprolactinemia side effect. Similarly, it doesn't cause hyperglycemia, no dyslipidemia, no sedation, no weight gain. So aripiprazole is a very good alternative if someone having side effects from risperidone or even olanzapine or quetiapine. So let's start with some of the question. One patient taking risperidone and having galacturia, your next option will be giving aripiprazole to this patient because it doesn't cause galacturia or hyperprolactinemia. If aripiprazole is not in the option, then next option is quetiapine. It also causes like not too much hyperprolactinemia, but best is aripiprazole. Someone on olanzapine and presenting to you with weight gain issues. You can ask them for lifestyle modification, but obviously you would like to change this olanzapine to aripiprazole. Okay, same with quetiapine, you can change with aripiprazole. Okay, these are very, very commonly asked questions, so make sure you understand it. Sorry. All right. Now we are just at the finishing. There are some of the psychotic disorder that you guys need to know. Remember, schizophrenia means patient needs to have those symptoms persistent for 6 months, right? What if similar kind of features, but that's less than 1 month? Let's see this question. A 35-year-old female Chinese immigrant brought in by neighbors after she was found wandering in the street. Anytime wandering in the street, think it that there is a possibility this patient has some mental disorder. Yelling out someone's name. She appears disheveled, grossly disorganized. You learn that she arrived in the US several days ago and upon her arrival witnessed the death of her 3-year-old son. While in the waiting room, she appears to be responding to internal stimuli. This appearing like appears to responding to internal stimuli, which means that they are having some hallucination. So might be patient is actually seeing her son. Anytime this is there responding to internal stimuli, that's hallucination. Okay, and patient having grossly disorganized behavior. So you got your two feature already, right? So this patient having psychosis. Now you need to know that is it brief psychotic disorder, is it schizophreniform disorder, or is it schizophrenia? So you can see here she learned that she arrived in the US several days ago. So obviously it's less than a month. So when these symptoms is less than a month, so symptoms more than 1 day, but less than 30 days, that's your brief psychotic disorder. All other features will be same. These patients also need to be treated. So you need to hospitalize this patient and start antipsychotics. What is schizophreniform disorder? Schizophreniform disorder is mainly patient having all these features, but the duration is between 1 month to 6 months. So presenting symptoms are same. Symptoms present more than 1 month, but less than 6 months. That is schizophreniform disorder. Treatment is same. Schizophrenia means patient having symptoms more than 6 months. There is a term called prodormal schizophrenia. Prodormal schizophrenia means patient actually doesn't have full-blown symptoms of schizophrenia, but some of the feature goes with initial symptoms of schizophrenia. So usually they say that patient was like a bright student, used to go to the school or university, but suddenly like patient is not going to anywhere, locked up in the room, not talking with anyone, not socializing, just total withdrawn. Sometimes symptoms like that can be a feature of prodromal schizophrenia, but there is no hard and fast rule that who we can diagnose with prodromal schizophrenia. It just depends that if this withdrawal features is a feature of prodromal schizophrenia or initial symptom of schizophrenia. So in the question, if they say that something like that, there was like if a parents come to you to consult about his son was a very bright student, went to the school and had a very good grade, but suddenly he stopped going to school, he stopped even going out of the room. Full time he's just doing nothing, just looking at the ceiling, looking at the room, not eating and drinking too much. So that's prodromal schizophrenia. Okay. For prodromal schizophrenia, there is no indication of starting the treatment, but we need to keep an eye. Sometimes you can start with some psychotherapy. There is another term called schizoaffective disorder. Now, this one, many of you will get a little confused, but don't get worried. See that this one is mainly two things. So patient will have features of psychosis and patient will have features of affective disorder. What are your affective disorder? Depression and mania. So if some patient having features of psychosis and features of affective disorder at the same time, that's schizoaffective disorder. So if you look at here, uninterrupted period of symptoms meeting criteria of depression, mania, or mixed episode. So patient will have features of either depression, mania, or both. With that, patient will have psychotic features and delusion hallucination for at least 2 weeks in the absence of any affective disorder. Now, even if you don't remember that, if you get a patient having both psychosis and mania or depression, diagnose it with schizoaffective disorder. Look at this question. 25-year-old woman is found walking nude in the shopping mall. When asked why, she replies, I am making it easy for others to have sex with me since I know they all want me. She states she heard a voice telling her she was irresistible and everyone wanted her. So, what is this voice? Hallucination. When she speaks, she cannot focus on one topic at a time. So, what is these things? Flight of ideas. Her mood is euphoric, affect labile. She recounts an episode last year. Although she did not have elevated or depressive mood, she heard voices that she cannot describe. So this one actually, like, she had a single episode of psychosis which was not associated with mood disorder. But at the moment, this patient is having hallucination and disorganized behavior, which means psychosis. With that patient having labile mode, euphoric mode, and flight of ideas, which means this patient having mania as well. So this patient having schizoaffective disorder, and the duration of symptoms should be more than 6 months. So bipolar patient will not have psychosis. Bipolar patient doesn't have hallucination. This patient can hear voices. That's why it's not bipolar. Okay. This patient also needs to be hospitalized. This patient has better prognosis than patient with schizophrenia, but worse prognosis than patient with affective disorder. For the treatment, start with antidepressant. If that doesn't help, then consider antipsychotic. Clear, guys? Schizophrenia things. So there are mainly brief psychotic disorders, so symptoms less than a month. Between 1 month to 6 months, that is schizophreniform. More than 6 months, that's your schizophrenia. Any question? Okay, let's just finish it here tonight. We'll do some like these delusional disorders and other topics we will discuss in any other class. That should be fine. Okay. So how did this session go? Did you feel it is helping you? Do you think like the lecture is important and you think like this is like relevant information that you need for your exam? Yeah. Look, that this is very important to feel in this way, that if you don't feel that you're getting help, if you don't feel that the teacher or the mentor who is talking is not making sense, then there is nothing you can get from them. So make sure whenever you join any course in your life, you should really love the session. Okay, so when you only love the session, then you will get benefit. Now, talking 2.5 hours is not very easy, but it's more difficult to give attention for 2.5 hours. You can only do that if you like the class. Okay, that's the only thing. If you don't like, you will sleep. Okay, trust me. Now, remember one thing that I say, that we are going to start a new course on 31st of March. And from 31st of March, you will have a 2 weeks free session with us. And also just, I think in 1 week time, you're going to get one MCQ question solvation class with me. I'm going to give you the schedule tonight. You will get it. Please have a look by morning so that you know the schedule and you can join it. The 2 weeks free session is like totally free for everyone. Even if you don't want to join the course, make sure you join it, just the 2 weeks, to get an idea. It will really help. And we will make another group just for those students who are interested for this 2 weeks free session. I already made a group. I'll upload the link of that group. Make sure you join that group, because all the recordings of the class will be uploaded there. You can join now also, Dr. Thomas. Anyone wants to join, give us a message in our messenger that you want to join. Or you can also send us email in First Aid AMC. Let me just give it to you in the chat box. So First Aid AMC 4536 at outlook.com. So if you just give us an email in here, just let us know that you want to join the course, then our team member will get back to you with all other next things. Okay, so make sure you email or message us in our messenger so that we know that you want to join and we can book you. Now, very good question, Dr. Benish. Now, I will not say that the lecture is 100% enough. No lecture is 100% enough. I always say that read JM, at least read JM. If you don't want to read anything else, you should read JM. Most of the JM topics will be covered by the lecture, but still, I would say by yourself read the JM just to give you the confidence. It's important. All right, now I'm going to show you the course, how it's going to happen, all the details. I know that most of you has already gone through it, the video, but it's still like, just have a look, that if you have any question, let me know. Okay, so I'll just open the video for you guys. All right, that should be all, I think. Okay, thank you so much for watching the video, guys. So, do you guys have any question? How can I join Messenger group? We don't have any Messenger group actually, but you can always ask questions through the Messenger. You can find my ID in the first aid MCQ. If you just send me message through your Messenger that you want to join, then I'll ask my team to give you the email and everything. So if you join 5 months course, all the lectures will be already available in the software. You can always access it. That should be fine, Dr. Shumi. We don't have any shorter course. That's the only course we are having at the moment. No, we don't have any other discussion groups, just only this one. So the notes are given the course students only. The course students usually get all the notes through the software that we provide. So just with login, they can access all the notes that we provide. All right. Any other question, guys? Any question you can always ask in our next sessions. We'll be there at least for 2 weeks. Okay. Yes, you can access from mobile. So the software access is until you pass the exam. That means all the notes and lecture materials. The video, that means the video recordings that we provide, you will get it for 10 months. So that's enough for your preparation. No course usually give you recordings for 10 months. Usually they ask for more money, I think, but it's just for your own benefit. And I know that most of you have suffered a lot for COVID. So just because I think that 10 months is enough for passing AMC MCQ. Like 6 months is enough, but some candidate take 10 months, even more than that, but 10 months is enough, I think. Don't go beyond 10 months. Yes, you can access like the all files and materials will be there for you unless until you pass MCQ. All right, thank you. Have a good night then. We'll see you in the next class. Have a look tomorrow that what is your next class schedule. I'll upload it tonight. Okay. Thank you everyone. Have a good night. Bye.